Good morning, everyone who's here in person and online. Welcome to Surgery Grand Rounds. We're really pleased this morning to have a visiting professor, Dr. Ian Pollack. I've asked Dr. Mandeep Tamber, who knows and has worked with Dr. Pollack in the past, to introduce him. We're really grateful that Dr. Pollack has come to Vancouver to visit us and to spend such a long time with us. He's here actually for a few days. He came yesterday, and he will be the Dr. Paul Steinbok visiting professor for neurosurgery tomorrow, where he'll be speaking at our rounds and having some teaching with our residents. We're really pleased that he has come to share his insights this morning about neuro-oncology and molecular profiling and surgery in pediatric tumors. And I'll ask Mandeep to formally introduce him. Thanks, Barry.
Thank you, and good morning, everybody. It's my humble pleasure to introduce Ian Pollack. As Gary mentioned, he's in Vancouver on the occasion of the 2024 Paul Steinbok Visiting Professorship in Pediatric Neurosurgery. Ian is very well accomplished, and I've had to make some notes in order to do due diligence for his introduction, but he's currently the A. Leland Albright Professor of Neurosurgery at the University of Pittsburgh School of Medicine. He graduated magna cum laude from Emory with a degree in chemistry, and then went on to Johns Hopkins for medical school, and then followed that up with internship and residency in neurologic surgery at the University of Pittsburgh. He started on faculty there in 1992, and the year prior he was awarded the prestigious Van Wegenen Traveling Fellowship by the American Association of Neurological Surgeons. And that fellowship allowed Ian to do an additional year of training. Part of which he spent at Sick Kids, which is also my alma mater, where he did some clinical training, and then he followed that up with some research training in neuro-oncology in Switzerland and as well as in Sweden. And then, like I mentioned, he was started on faculty at Pittsburgh in 1992. If you don't know about the Van Wegenen Fellowship, it's obviously named after William Van Wegenen, who trained under Harvey Cushing, and under Cushing's guidance, he was encouraged to travel to Europe to get a more rounded education, not only in clinical neurosurgery, but the basic science foundations of neurosurgery. And Ian has basically replicated that path in the contemporary day. His research accomplishments are vast. He's author on more than 410 peer-reviewed publications, and he's edited numerous books in neurosurgery and specifically related to neuro-oncology. I think every practicing pediatric neurosurgeon has a copy of the Principles and Practice of Pediatric Neurosurgery on their bookshelf, and Ian was a co-editor of that text. It's a seminal volume in our field. He's PI on many NIH grants, specifically directed on brain tumor therapy and novel therapies thereof, including immunotherapy for childhood brain tumors, and he'll talk about some of that work this morning. He spent the past couple of days down in Albuquerque for an oncology consortium meeting. He chaired the Children's Oncology Group for a decade between 1999 and 2009, and was also co-chair of the NCI Brain Malignancy Steering Committee between 2010 and 2017. Ian is a triple threat. He's obviously a clinically excellent physician, and I've already talked about his research pedigree, but he's also has many administrative honors. He was the vice chairman, or is the vice chairman of academic affairs at the University of Pittsburgh, Department of Neurological Surgery, and was the chief of pediatric neurosurgery at the Children's Hospital for over 20 years prior to giving up that responsibility earlier this year. I was fortunate to be recruited by Ian back in 2009 and was very privileged to benefit from his wisdom and guidance over the formative years of my career. Welcome, Ian, to Vancouver, and we're going to look forward to spending the next couple of days with you and learning.
Thanks for the nice introduction. Vancouver's got a long history of neurosurgical greats with Paul Steinbok and Doug Cochrane, and I've had the privilege of visiting them both here and at various meetings around the world. And of course, I had the privilege of working with Dr. Tamber for many years in Pittsburgh. Unfortunately, the pull to come back to Canada was too strong, so he wound up coming back to Vancouver a number of years ago, and has continued an excellent academic career. What I'm going to talk about today is something that I focused on for a lot of my career, which is surgery for brain tumors, and also studying the molecular profiling of brain tumors, as well as therapeutics. But I'm going to focus on the role of surgery, since this is a surgical conference, and I have no conflicts of interest to disclose. For those who don't know, this is downtown Pittsburgh, the Three Rivers, where Monongahela and the Allegheny join to form the Ohio. And it's also known as the City of Bridges because we have tons of bridges over all these rivers. So it's a beautiful place. It's not really a steel town anymore. It's more high-tech and infotech and biotech. In terms of my talk, brain tumors are the most common solid tumors of childhood. They have the highest mortality rate now. And although we've made major improvements in the treatments of some types of tumors, there are many other types that remain resistant. From a surgical perspective, there are many types of tumors where we as surgeons have a big impact on outcome. Extent of resection is associated with outcome for many types of tumors. But more than just the surgery of removing the tumors, we also have a role in providing tissue for molecular classification, which has now become sort of the standard of care for categorizing and treating these tumors. And I'll show you some examples. So since I can't talk about all the types of brain tumors because there are many that are sort of rare, what I want to focus on are the most common ones, high-grade and low-grade gliomas of the supratentorial region and also the midline region. And then I'll talk about posterior fossa tumors. And these are areas where the classifications really have evolved over the last several years. So low-grade gliomas, according to the current recently published World Health Organization classification, are classified into circumscribed tumors, very well delineated, diffuse tumors, and glioneuronal tumors. And this slide here is an example of a common circumscribed tumor of pilocytic astrocytoma. And this one is an example of a diffuse tumor that had a MIB mutation. And although the goal for both types of tumors is to try to remove them all, it's certainly more difficult for the diffuse tumors. So in case there are any pathologists out there in the audience, this is the typical appearance of a pilocytic astrocytoma. It has this biphasic pattern where they're pyloid appearing cells with these little red things called Rosenthal fibers. And then there's a vacuolar area that looks entirely different. So that's sort of a characteristic of these tumors. Now, I mentioned that this is still a surgical disease. Tumors that are amenable to gross total resection have a substantially better outcome than those that have incomplete resections. So as surgeons, we try to get a gross total resection when that's feasible. Sometimes that can be challenging. This is a tumor that's in the dominant motor cortex of, unfortunately, one of our floor nurses. So you can imagine my angst level was fairly high in operating on this child. She presented with a single seizure and had this pretty well circumscribed tumor. And the challenge was how to get to it without injuring the motor cortex and language cortex. And we did something called diffusion tensor imaging, which maps out major pathways. This pathway in green is the motor pathway, and the tumor is right behind that. And we also mapped out hand movement and speech. The tumor was nowhere near speech, but it was quite close to hand movement, in fact, right in front of the tumor. So we took an approach that came in from the back and were able to do a gross total resection of the tumor. And there are lots of fancy tools that we have nowadays to get a gross total resection that we didn't have 10 or 15 years ago. So the field has really changed in terms of the surgical parameters. In contrast to the hemispheric low-grade gliomas, where we always try to get a gross total resection, midline tumors are a lot more challenging. These really need to be managed on a case-by-case basis. A well-circumscribed tumor like this might be amenable to extensive debulking, which is what we did. A tumor like this, which is in a child with neurofibromatosis, you can see that the tumor involves the optic chiasm in both optic nerves. And on this FLAIR image, you can see that there's tumor tracking posteriorly into the occipital cortex. And this is, needless to say, not a tumor that we can totally remove. And you can even make the diagnosis based on the MRI alone. So in many cases, these tumors are not even biopsied. There are some tricks, as I mentioned, to help remove these tumors. So this was a low-grade glioma of the thalamus in a 3-year-old who presented with hemiparesis. And we did mapping and found that the corticospinal tract ran just medial to the tumor. So we took an approach that went laterally through the middle temporal gyrus, and were able to get a gross total resection of the tumor. There are other tumors like this where the motor pathways are pushed laterally, where we would take a different approach coming in from the top rather than the side. Another example of a low-grade glioma, this is a child with neurofibromatosis, a common associated finding with low-grade gliomas. And you can see that it's a globular mass involving the optic chiasm. And this child was treated with chemotherapy and has done well for about 15 years since this initial scan. Never needed surgery or radiation or anything else. On the other hand, this gigantic tumor was a pilocytic astrocytoma. I did a central debulking of the tumor just to try to make more room and open up the ventricles. But needless to say, I left a lot behind. This is the MRI appearance after 10 weeks of chemotherapy. So this is a tumor type where there is definitely a role for adjuvant therapy, chemotherapy, and more recently, biological therapy. The progression-free survival in these tumors with conventional chemotherapy is still not great. This is a phase 3 randomized trial that I was involved with. that compared the two most active chemotherapy regimens. And what you'll notice is that the 5-year progression-free survival was only about 50%. So there was plenty of room for improvement in terms of approaches. And around the same time, it was recognized that most of these tumors have abnormalities in a molecular pathway known as the MAP kinase, or mitogen activated signaling kinase pathway. And the majority of them have fusion mutations that activate the BRAF gene. There are others that have mutations in NF1, and this operates by the same mechanism, by driving signaling through MAP kinase. And then there are a host of less common mutations. But as it turns out, about 95% of these tumors are MAP kinase driven. And this has led to some very exciting studies that have really changed the field in the last probably 10 to 12 years. This is the first trial that was done, and it was a phase 1 trial within the Pediatric Brain Tumor Consortium. And I show it because usually when you do phase 1 studies, you don't expect to see anything really exciting. You're doing pharmacokinetics, you're looking at, toxicity profiles. And what we found on this waterfall plot, which shows the change in the size of the tumor as a function of treatment, that most of these histograms are pointing down, sometimes by quite a bit. And about 75% of these tumors responded to this particular agent, selumetinib. This led to some phase 2 studies, and now we are doing a bunch of phase 3 studies within the Children's Oncology Group that are comparing selumetinib versus conventional chemotherapy, first in newly diagnosed patients and also in recurrent patients, patients with NF and patients without NF. So the way we manage these tumors beyond surgery has changed enormously over the course of the last decade. And there are combination trials for tumors that have BRAF V600E mutations. And the group from Toronto actually demonstrated that these tumors respond much less favorably than the BRAF fusion proteins mutations. So they often require a couple BRAF and MAP kinase targeted chemotherapies. Now I'll change gears a little bit and talk about high-grade gliomas. Back in the old days when I was getting started, people used to think that high-grade gliomas in kids were much better than high-grade gliomas in adults. In reality, that is probably an oversimplification. There are many subtypes of high-grade gliomas in kids. Some do pretty well. Some do just as badly as high-grade gliomas in adults. And they have distinct molecular genetic profiles. There is a role for surgery. This is an old study that showed that tumors that were amenable to extensive resection did substantially better than those that were not. But it turns out that probably reflects more the biology of the tumor than the skill of the surgeon, even though we like to think we're making a big impact. So this was a very large high-grade glioma in an infant that I took out. This is what the tumor looked like at surgery. You'll notice it seems to be fairly well circumscribed for a malignant glioma, and we were able to do a complete resection and then treated this child with chemotherapy. But as time has gone on, we've realized that there are different subsets of these tumors. So this is a thalamic high-grade glioma, a midline glioma. And midline gliomas are now known to do substantially worse. I found out that the hard way in this particular case. This is a tumor in a 3-year-old. This is what the tumor looked like on CT and on MRI. And I did what I thought was a pretty nice resection. There's a little bit of tumor left right here, but for the most part, we got a gross total resection. This would be considered in that favorable group if you just looked at resection extent. But this is what the tumor looked like 5 months postoperatively after radiation and chemotherapy. The tumor grew back. It disseminated through the ventricles. There was leptomeningeal spread. So this was clearly a different beast than the supratentorial well-circumscribed tumors. And we began doing molecular studies in the late 2000s and into the 2010s. And what we noticed was that there were different subsets of these tumors. We identified one subset that has IDH mutations. These are commonly seen in young adult malignant gliomas. And as it turns out, none of 23 kids that were younger than 14 had these mutations, but they were seen in 35% of kids that were older than 14, so the teenagers. And they had a much more favorable prognosis than the ones that didn't have these mutations. So this gave the first inkling that there might be a difference in outcome in high-grade gliomas in kids as a function of molecular subtype. And things have gotten way more complicated since then. We know that there are a subgroup of tumors, the midline tumors, that have histone mutations, particularly involving the H3K27M gene. And these tumors do terribly. And then there's a group of hemispheric tumors that have an assortment of mutations. These do much, much better. And then there are a bunch of other tumors that have an assortment of mutations. All of these are potentially amenable to molecularly targeted therapies if we get the right agents. And so that remains a work in progress. These are some results from a group in Europe that unfortunately beat us to publishing the exact same data. They looked at IDH mutant tumors, and like I had shown a moment ago, those do much better than all the other high-grade gliomas. They showed that tumors that had H3G34 mutations, which tend to be hemispheric tumors in older kids, have an intermediate prognosis, and those that have K27M mutations, like the one that I showed that disseminated, unfortunately do terribly. And then there's this mixed bag of other tumors that have different kinds of mutations that are sort of in between in terms of prognosis. So we now tailor our treatment based on the molecular characteristics of the tumor. This is just a small subset of tumors, of trials that are being done in the Children's Oncology Group that look at many different molecular subsets of high-grade gliomas.
Morning. Coffee time. You too.
And this has become sort of the pattern for the management of these tumors, which is stratifying them based on their molecular profile, not treating all high-grade gliomas exactly the same. Now, this same philosophy applies to the infratentorial tumors, and I'll go through some of those. The two most common ones are cerebellar astrocytomas, which are very much like supratentorial astrocytomas, and medulloblastoma, which is the most common malignant subtype of brain tumor in adults. I'm sorry, in children. So infratentorial tumors, low-grade gliomas, pretty much have the same mutational pattern as low-grade gliomas in the hemispheres. And as neurosurgeons, we like taking out these tumors because they're reasonably well circumscribed. Even big, kind of scary-looking tumors like this can be completely removed. They do very well. The goal of our initial surgical approach is to try to get a gross total resection if we can. The one thing that limits us in rare cases are those tumors that involve the brainstem. And for those, the management sort of parallels what's done in low-grade gliomas supratentorially, which is using chemotherapy or molecularly targeted therapy, or in older kids, radiation therapy. I'll show you the operative technique. This is another subtype of low-grade glioma. This is a hemispheric tumor. The one that I showed a moment ago was a vermian tumor. They differ just as a function of location. These tumors are, again, well circumscribed. You can pretty much draw a line around the border of these tumors. And at surgery, we position these patients prone, either in head pins or in younger kids using a horseshoe. And then we make a suboccipital craniotomy. We make burr holes over the area below the transverse sinuses down to the foramen magnum here. And this is an old retractor system that was designed by my first program director, Dr. Janetta. So I have it here for just kind of historical significance. We use different retractors nowadays, but the effect is the same. And this is what we wind up seeing. This is the entire posterior fossa that we can see exposed. If you'll notice this big red thing, that's the tumor. And on the opposite side, you can see the cerebellar folia. The tumor is easily separated from the surrounding area just based on its appearance. And so we try our best to take these tumors out completely. The other big type of posterior fossa tumors are the medulloblastomas. These used to be called PNETs, primitive neuroectodermal tumors. That has since fallen out of favor. And the World Health Organization recognizes these as medulloblastomas again. The 2016 classification is shown here. But even before that, we separated these tumors into high risk and low risk. A pretty dumb, simple separation. Low risk tumors were tumors that were completely localized and could be extensively resected. They had no metastases and they occurred in children older than 3. And then we got a little smarter and we learned that there are histological subtypes of medulloblastomas, anaplastic, classical, and desmoplastic. And then we got even smarter still and realized that there are genomic subsets of medulloblastomas. And this classification from 2016 was the first that took that into account. and subdivided these tumors based on these molecular characteristics. The 2021 classification is almost identical, except being a little more complicated and harder to read on a slide. But the difference in outcome as a function of subtype is quite dramatic, and I'll show you that in a minute. So there is a role for surgery in these tumors, even though they do have different subtypes. This is an old study showing that those tumors that were amenable to extensive resection did much better than those that were not. This 1.5 centimeter cutoff point is just something the radiologists came up with. It was an amount that they could measure easily on a CT or an MRI scan. So there's nothing magical about 1.5 centimeters squared, but that's what we use in a whole bunch of studies. And even as we subdivided these tumors into different tumor types, the impact of resection extent remained. And so our goal when we see a tumor like this is to try to take out as much as we can. And this is a medulloblastoma. You can see the brainstem in the front, the cerebellum in the back being pushed in opposite directions. And at the end of surgery, we want to wind up with an appearance like this, where there's no obvious residual tumor. Now, that is sometimes easier than it sounds, or I should say harder than it sounds. This is the typical appearance we see in a medulloblastoma. Here are the cerebellar hemispheres. The tonsils are out this way, and the vermis is here. And there's a little bit of tumor in the cisterna magna. But the part that we're seeing on that exposure is a little bit right down here. The entire tumor is up in this area. So we have to somehow get to that tumor. And the way I approach these is first defining a plane, at least for a couple centimeters, between the tumor and the fourth ventricle. So I kind of have an idea how deep I can go. And then, whoops, let's see, I'm going the wrong way. And then we debulk the central part of the tumor. We try to send large amounts of tumor to pathology for molecular classification and histology, and also for banking. We then elevate the vermis, something called a telovelar approach, or we can make a small opening in the vermis. And then I try to dissect the plane between tumor and cerebellum up until I reach the top, and then work my way down along the floor of the fourth ventricle, which is the most treacherous part of the operation. And this is the appearance we get at the end. This is the aqueduct, really beautiful view, a median raphe of the fourth ventricle, and this little bit of tumor here in the brainstem we're comfortable leaving behind. And I always bring a new neuro-oncologist when we have one into the OR and have them take a look at that. So even though the radiologist may say, oh, the surgeon did a total resection, in reality, we're kidding ourselves. We're not doing a total resection. We're doing an extensive subtotal or gross total resection. But that's adequate for these kind of tumors because they respond well to chemotherapy and radiation therapy. Back in the old days, like when I was starting out. The treatment of choice for these tumors was just radiation. And they would get 3,600 centigrade of radiation in the posterior fossa, and then they'd get a boost dose, or I should say 3,600 to the craniospinal axis, and then a boost dose to the posterior fossa to 5,400 centigrade. Now in a 5-year-old, giving that much radiation is pretty much guaranteed to knock off 30 IQ points. So the goal of some of the early studies was to see if we could reduce the dose of radiation. And this is a study that was done. The blue ones show standard doses and reduced doses of radiation. And you can see the reduced dose radiation group did significantly worse. Then somebody got the great idea to add chemotherapy to radiation. And the next series of studies used reduced doses of radiation, 2,340 to the craniospinal axis, with chemotherapy. And these are two regimens that were tried, and they were virtually identical, but they were better than anything that had been achieved with radiation alone. And that became the new standard of care, giving chemotherapy with radiation. Then we try to push the envelope even further by reducing the radiation dose to 1,800 centigrade. And that's getting to the point where you're not really knocking off much in the way of IQ. And we also tried to reduce the volume of radiation to the posterior fossa using a stereotactically defined dose to the tumor bed versus a dose to the entire posterior fossa, followed by chemotherapy. And what we found from that was we could reduce the volume of radiation to the posterior fossa. The two volumes are shown here. They're virtually superimposable. But if you look at the effect of radiation dose on outcome, the group that got a lower dose, shown in black, did significantly worse than the group that got a higher dose. So there's a limit to how much you can reduce the dose of radiation for medulloblastomas as a whole. I'll come back to that in a minute. The outcome for metastatic, so-called high-risk medulloblastomas has improved over time as well, with the addition of chemotherapy during radiation in addition to after radiation. This is chemotherapy during radiation. This is chemotherapy only after radiation. And this was statistically significant. So that led to a series of additional trials looking at, in a phase 3 context, comparing the use of carboplatin with radiation versus not. And while all these studies were going on, we were sort of in the dark ages of classifying these tumors. And groups from around the world, including Boston and Toronto and Europe, showed that there were actually at least 4 distinct subtypes of medulloblastomas. They were known by different names. Some were called Wnt tumors, that's shown in blue here, sonic hedgehog tumors shown in red. Why somebody would name a gene sonic hedgehog, I have no idea. They must have spent way too much time in the lab, but they have a subset that is named the sonic hedgehog subset. And this green line is group D, and the yellow line is group C, also known as group 3, and they do substantially worse. And the frequency of these tumors varies as a function of age. So when you look more closely at that old data that I showed you on medulloblastomas, and you subdivide them based on their tumor type, which nobody knew at the time that the study was being conducted, the group 3 tumors do dramatically worse than any of the other subsets. The Wnt tumors do very well. Most of the tumors in the standard risk group turned out to be group 4 tumors. And that was the group where radiation dose had a major impact on outcome. In all the other groups, there was no significant difference. Now, the high-risk medulloblastoma study compared the use of carboplatin or not. And so looking at that, you would say carboplatin is much better than not using carboplatin. But I don't know if this is going to show well enough. The difference was seen mainly in the group 3 tumors. And there wasn't a significant difference in any of the other subsets. So we now have trials that are subdividing these tumors based on their molecular subsets. Now, this is kind of what we knew in the mid-2010s. There were 4 subsets of tumors. They did differently. It turns out there are a lot more subsets than we ever thought existed. Some groups say there's many as 13 subsets. The challenge to that is we wind up having a lot of much smaller trials. We're not doing 500 patient trials. We're doing trials that have 35 patients. So an example is a study of reduced dose radiation and reduced chemotherapy in Wnt-driven medulloblastomas. That's the best subgroup of tumors. And these are molecularly classified before they go on to treatment. They get a reduced dose of radiation, 1800 gray. And they also have a reduced dose of chemotherapy. And why is that important? Because cisplatin has a very negative effect on hearing function. So we had a lot of patients from some of our older studies who had deafness as a major long-term complication. That study just completed. The results seem promising, but haven't been published or formally released. But I think it kind of sets the stage for other studies where we are categorizing these tumors very precisely. Now, the next group of posterior fossa tumors I'll talk about are the ependymomas, and this is truly a surgical disease. The best outcome occurs after a gross total resection. These tumors tend to recur locally, and they're treated with local radiation, either to the posterior fossa or the supratentorial area. And although we just completed a study looking at the role of chemotherapy, that has yet to be analyzed. So we don't know whether chemotherapy improves outcome. This is an old slide from our institution, but it just shows how dramatically resection extent affects outcome. So tumors that are amenable to gross total resection do dramatically better than those that don't. And so if you do an incomplete resection, the odds are high that the patient is eventually going to die. So we try to do a gross total resection every time we can. This was a 2-year-old who had a gigantic ependymoma. We weren't quite sure what type of tumor it was, but it looked like an ependymoma based on its growth pattern. We monitored every cranial nerve we could along the floor of the fourth ventricle, 3rd, 4th, 5th, 6th, 7th, 9th, 10th, 11th, 12th, and brainstem responses and dorsal spinal cord responses. These tumors are deceptively well circumscribed. When you're working on the surface, it looks like, oh, taking one of these out should be a piece of cake. But when you get along the floor of the fourth ventricle, it gets much more treacherous. We were able to get a gross total resection on this one, but that's not the case for all of these. This is a child that presented in the ER in extremis. The kid was super sick. We did a CT scan and he went straight to the OR. I did a pretty extensive resection, but as you can see from the MRI, there's tumor left in the medulla. And the reason for that is every time we tried to remove that last piece of tumor, the child became asystolic, which made the anesthesiologist a bit uncomfortable. So we stopped and said, enough is enough. And then we treated the child with chemotherapy. This is what the tumor looked like after 6 weeks of chemotherapy. It seemed like it had come out of the brainstem. We went back in and did a gross total resection. And this sort of an approach has now been built into all of the ependymoma studies. They all include a second look surgery component because these tumors are, in many cases, amenable to second look surgery. Now, not all of these tumors are resectable. This is one from one of my colleagues. Early in my experience as a faculty, and he had done an extensive resection, but there was a lot of tumor left behind. And I thought, I'm going to go in and I'm going to just take out the rest of the tumor. And that was not possible. The tumor was stuck to the brainstem along the side, was stuck to every cranial nerve. It wrapped around the basilar artery, and I was able to debulk it a lot, but I couldn't get a gross total resection. And it became apparent as these tumors were being analyzed molecularly that there are different subsets of ependymomas. So we used to all include these as ependymomas. One big group, treat them all the same, they all respond the same. The reality is there's at least 9 different subsets of medulloblastomas. And there's one group in the posterior fossa called posterior fossa A that tend to grow around the brainstem in young kids. They have a much worse prognosis. And that's what we were dealing with in that unresectable case. The treatment of these has yet to be stratified extensively based on molecular subtype, but that is actually something that's a work in progress, and we were discussing that at our last PBTC meeting. So it will happen, it's just a matter of time. The last subgroup of tumors I'll talk about are the diffuse brainstem gliomas. These, unfortunately, have a terrible prognosis. They present with rapidly progressive cranial neuropathies, and the outcome has not improved in 30 years. This is a study that I was a co-chair on back around 2000. We used high-dose hyperfractionated radiation and chemotherapy, really as intensive treatment as you could possibly give. And the 1-year progression-free survival was only about 20%. And no study has done any better. So we're now trying to be a little more adventuresome in the management of these tumors, using convection-enhanced delivery of immunotoxins that we slowly pump into the brainstem, as well as chemotherapy. These have been slow to develop in fits and starts over the years, but we are moving in that direction. We also are doing studies guided by biopsy data Used to be biopsies were never done in brainstem gliomas, and now they're starting. The preliminary results using biopsy data to try to subdivide treatment haven't been positive, but maybe we haven't found the right agents yet. So we have more work to do. And then my group has been involved in immunotherapy, and I'll actually talk a bit more about that in terms of developing an academic career in my talk tomorrow. But there are promising results with immunotherapy. Now, I shouldn't say that all brainstem gliomas do terribly. There are a subset that are biologically benign, minimally invasive, and amenable to debulking. And these tend to involve the cervicomedullary junction, those that are exophytic from the brainstem, and those that are focal and intrinsic. And this is an example of a child I treated 18 years ago with this tumor that looked like it was coming off the brainstem. And I was able to do a gross total resection, shaving it flat with the brainstem surface. And really what this is a pilocytic astrocytoma, just like any pilocytic astrocytoma that arises in the hemisphere or the cerebellum. They can be completely removed. So not all brainstem gliomas are hopeless, and it's important to recognize the diffuse ones from the non-diffuse ones because they need to be treated very differently. So I'll sum up here. I know I've covered a lot of tumor types, and what I wanted to convey is that surgery plays an important role in the management of many types of pediatric brain tumors, not only by establishing the diagnosis and relieving mass effect, but also by providing tissue for molecular stratification. And that is becoming as important as the surgery itself. The appropriate approach to treatment is determined both by the anatomy of the tumor and the histology of the tumor, but our dogma may be influenced by new genomic insights. And our approaches to, for example, midline low-grade gliomas of the hemispheres, where we used to treat them with chemotherapy, and if they didn't respond, we'd zap them with radiation. Or even further back, there were neurosurgeons that would try to lop these tumors off, and a lot of the kids had major side effects. Those have all gone by the wayside, and now we have molecularly targeted agents that are very effective against these tumors, with disease control rates going on past 5 years. So there's been a lot of changes in the field, and our role as surgeons is to help drive those changes by providing enough tissue that we can really do a detailed molecular analysis. So I would like to thank everybody for their attention, and those that are out in video land, be happy to take any questions. I just want to say it's a great pleasure coming here. I feel very honored to be invited. And I look forward to spending some more time in Vancouver. Thanks.
Thanks, Ian. Thanks for walking us through the multimodal approach to brain tumors in children. I think you set the stage perfectly for the advances to come in the next decade. I mean, we can make surgery incrementally safer, or maybe get a few more gross total resections with imaging intraoperatively, but the real advances are going to come from molecular profiling and targeted therapy, like you alluded to in your talk. So thank you for that. Questions from the Zoom audience first, please.
Mandy, Felix, can I ask Ian a question?
Yes, sir.
Okay, Dr. Pollack, welcome to Vancouver. I actually met you when I was visiting Sekar and Company, and I was doing a little postgrad stint at the University of Pittsburgh. So it's beautiful to see you come. I wondered, since you have enhanced and emphasized the role of surgical resection and growth as gross as possible, can you tell me, not in the supratentorial area, but your experience in the posterior fossa, has image guidance made any difference, or do you use it at all in the posterior fossa?
I tend to use image guidance in almost every case that I can, and part of it is because it gives me a level of comfort. We have an intraoperative MRI scanner as well, so all those techniques make me feel a little safer when I'm operating around gray areas where the tumor begins to blend into the surrounding brain. I'm not sure how far I've gone, and having feedback from the image guidance system, an ultrasound, or an intraoperative MRI gives me more confidence if I'm trying to do a gross total resection that I'm not going to hurt something. And we also we rely very heavily on monitoring, for our posterior fossa tumors and even for our supratentorial tumors.
Thank you.
We have a question from Dr. Sylvia Chang. How are you currently approaching biopsy of brainstem high-grade glioma? Do you recommend biopsying at all?
So I actually take a middle ground in those. There are some neurosurgeons nowadays who are biopsying all brainstem gliomas just for the sake of getting tissue. I biopsy those that have an atypical appearance, where I'm not sure it's a diffuse intrinsic pontine glioma. And then I will do biopsy if it affects the treatment. So if there are certain studies where having biopsy is essential, and I think you can justify the risk of the biopsy if it gives the patient and the family the option of joining a trial that they otherwise might not be able to. Doing it on a routine basis, I'm not in that camp yet, because the risk is small, but there's definitely a risk. And in a child with a 9-month event-free survival, you don't want them to lose any of that.
Thank you, everybody. Thanks again, Ian, for that great talk. If you're interested, you're welcome to join us tomorrow for our neurosurgery rounds. I think that circular went out, but Ian will talk more about the immunotherapy piece, which he touched on today. So with that, I'll conclude this morning, and have a good day.